This is meant to be interactive. This is one of my favorite conferences. I talk a lot, as does Rob and a lot of other people. But these are always the best for me because it's really with patients, right? Usually I'm presenting Kaplan-Meier curves to a bunch of doctors, specifically cardiologists, and their goal is to try and beat me up usually at these meetings. So it's to shoot arrows. And so for here, it's actually something that is meaningful and may translate into some sort of potentially life-altering opportunity for you all. So I hope that that's the case. I don't need to lecture to this group. You could lecture me about Fabry. But as you know, X-linked disease, progressive disease, life-threatening disease. And part of the reason that cardiology is a component of all of this stuff is, I'm sure if you heard from Eric Wallace or someone, they would say the heart's just there to pump blood to the kidneys, right? That's the only reason you need me. But it unfortunately really is the driver of mortality, leading cause of mortality in Fabry, as it is in a lot of other LSDs. So this is just something to keep in mind. And so understanding your cardiovascular health is really, really important as a patient. And you guys are aware of this as well. You know, this deposition starts in utero and is progressive, right? And so cardiologists, there's a lot of data coming out about this now, is that medicine, unfortunately, is geared towards dealing with disease. When people manifest, as you heard from Rob talking about heart failure, or kidney failure, the problem with that is that we can react to it, but the horse is sort of already in another county. It's not even out of the barn at that point, right? If you experience heart failure, that is a problem. What has changed your trajectory unequivocally. And so our goal is to try and be as proactive as possible. And that's why we've always been advocates of early therapy, early diagnosis, early intervention. Because once you get to that point of where you're having organ failure, even symptoms when it's related to heart disease, that's significant. And we'll talk a little bit about that, but also how can we kind of be proactive? And this is a slide that we show, and I would argue it actually is incorrect. And when I'm specifically talking about cardiac dysfunction, but I could make the same argument for renal insufficiency and other things as well, is usually when we talk about when are things involved, quote unquote, a heart, a kidney, a lung, a brain, it really is dependent on the tools that we're using to look at that organ, right? So are we doing something like a simple urinalysis, or are we doing a kidney biopsy? Are we looking at an echocardiogram, or are we looking at a PET scan for the heart? Very different modalities. And I think of it as akin to a microscope. I'm a bit of a simpleton about these sorts of things. If you look at things with your naked eye, you see one thing. If you look at with an electron microscopy, you see something very different. And that's the same sort of reasoning that I leverage in these cases as well. So this is a list of, and it's pretty much everything I do in cardiovascular medicine. The takeaway for Fabry is anything that you can think of related to cardiovascular disease is probably a possibility, okay? So things like you hear about left ventricular hypertrophy when we look at cardiac endpoints like you were just hearing about for studies, and that's just thickening of the heart, right? And that's the common manifestation. But if you think about, if your heart is already thick enough for me to detect on an imaging study, that's advanced disease, right? So how could we get upstream of all of that? High blood pressure is very common, not only because of kidney disease, but because the blood vessels themselves are impacted, right? And the autonomic system, which controls the vascular tone of those blood vessels. The way the heart's electrical activity works can be disrupted, and we'll talk a little bit about that. The valves, so the doors between the chambers and the heart, can be affected. We know the big tube leaving the heart, called the aorta, the largest artery, can become dilated in patients with Fabry. We know early heart attacks are a problem, and that's something that we probably don't pay as much attention to as we should, because obviously, you know, heart attacks can be fatal. So that's something that we'd want to avoid if we can. And then this idea of sudden death, how can we get at patients who we know might, for whatever reason, just have a cardiac arrest, could be walking down the street? How can we anticipate those things and potentially avert that condition? And we'll talk a little bit about some of that stuff too. And the question as scientists is always, well, why? I get it. It's Fabry and we see all these things. but we try and look for cause and effect sort of relationships in medicine, right? There's one thing to have an association, but then is it really causative is sometimes a harder thing to explain. But this is kind of some of the basic sort of understandings. You get this sphingolipid deposition in all these different areas, and that sort of underscores all of the cardiac pathology that I described on the prior slide. So, and it's even more complex than this, but at least gives us sort of a platform to think about these things. And this is kind of when we think about it, and I want you to think about the heart kind of in two buckets, if you will. One is the muscle. So that's what I do for a living. So it's called cardiomyopathy, or heart muscle disease is exactly what that's translated directly. But the other component is the electrical system. Okay. And we focus a lot when you see your heart doctors or your general doctors about Fabry. They're usually really focusing on the muscle component, okay? And that's really important. We're going to talk about that today. But the other big component is the electrical component. And when people die suddenly with Fabry, it is not because of heart muscle disease, okay? So I'll say that again. That is not the cause of sudden death. Usually is an electrical problem, okay? And we'll talk about that. People that have heart failure that have mortality associated with that, that's the slow sort of spiral disease that we see where people just kind of progressively dwindle. Their end organs become dysfunctional, and then they have a catastrophic event. So these are some of the things that we're going to talk a little bit about. And this, I think, is an interesting slide. And it kind of gives you a lot of the buzzwords. So if you want to sound cool and, you know, talk to your providers or even challenge me or Hopkin or anybody about, there's a lot of complicated stuff on this slide. But this is kind of where we would say the cutting edge is in the care of Fabry and cardiovascular disease. And we're going to touch on a lot of these things today. And you've heard about some of them already today. But specifically related to the heart, if we really want to, as I said, you know, I'm going to show you some pictures of echoes, which is an ultrasound of the heart, right? And you see the thickness of the heart. That doesn't require a lot of complex thinking. We know it's thick. But as I said, the problem is that that's a problem at that point. So how can we get upstream of that? So meaning, what are the heralding events to point me towards the direction that someone's going to have hypertrophy? What is the harbinger of that? That's what a lot of these things are. And that's what we're going to talk about. And that's what we want to empower you when you go back and see your providers to ask for, right? So, and this is just kind of how, you know, we talked about, you go from sort of a kind of a preclinical or pre-symptomatic kind of phase where you don't really have evidence of disease, but we know deposition is going on, meets a certain threshold. Then you start seeing organ involvement, then needs another threshold to become symptomatic, right? After that, have end organ dysfunction. The point is, we don't like it when we get to the right, okay? We want to stay to the left if at all possible. So we touched on some of these things about what are the sort of big deal findings in Fabry and what should you be paying attention to. And these are big for a simple reason. Once you have them, you either may die from it, right? Which is bad. But the other piece is that once you experience these things, I can't take you back. Once you have a heart attack, once you experience heart failure, once you have a stroke, the idea of going back to baseline or normal or wherever you was is just not achievable in 2023. Okay. So the point is, we want to avoid all of these things if at all possible. As I said, cardiovascular disease is a leading cause of mortality. Currently, it was kidney disease prior. And I think a lot of that sort of change, and I'd be curious to get the other speakers' thoughts, but I think it's because we focused a lot on the kidney and outcomes based on kidney outcomes with our interventions. Now we're starting to move more into cardiovascular focused outcomes, as you just heard, which I think obviously selfishly as a cardiologist is a good thing. But it also is still a big driver of mortality. So we don't want cardiovascular disease to continue to be the leading cause of mortality. We would love to see that number change. So there's nothing magical about what I'm going to tell you today. These are things that are available in most centers, and they're not like crazy cutting edge you have to fly to Stockholm to get. These are things that you can do in most centers nowadays. But what I enjoy about these conferences is giving you information that you otherwise may not have currently. And as a field, the only way people are going to learn about Fabry disease oftentimes is through you. That's just the reality of this. I joke about this, but I'm not joking. All cardiologists learn about Fabry disease. All of them do. And it's to study for our certification exam. Okay, so we all take a board exam. And then I have to take a recertification, blah, blah, blah. The minute after that exam, about 99% of them forget about Fabry. So they have heard about it. That I'm confident of. But do they remember it and do they think about it in everyday clinical practice? No. No, they don't. So how is it we can rekindle that knowledge? It's through you guys. That's how you do it, right? You go to an ER, you go to a community cardiology practice, a community nephrology practice, and you say, I have Fabry, can you help me? They're going to walk out of the room, pull out their phone, and Google Fabry. Just telling you confidently, that's what's going to happen. The best way that we can help you is you go empowered with information, viable with information with Veritas, right? That comes through these sorts of organizations to say, this is what I need you to do. Okay. And it's a partnership at that point. They're going to help you and you're actually going to educate the providers along the way. So just keep that in mind. This is some of the pathophysiology that I won't bore you too much with. You heard a little bit about steroids and some other things in some of the prior talks. At the basis of most of what we do in cardiovascular medicine, independent of Fabry, so people have atrial fibrillation or heart attacks or whatever, almost all of that has an underpinning of inflammation, okay? Almost everything that I do as a cardiologist is inflammation. And that's a big part of the driver of what's going on and what drives that inflammation. This particular disease, in part, is because of deposition, right? And that leads to a lot of downstream negative effects. So I told you two big buckets. One is kind of electrical, one is muscle. We'll talk about the electrical first. So arrhythmias, in my mind, are the things that we pay the least amount of attention to in any kind of cardiomyopathy, including Fabry-related cardiomyopathy, okay? So remember, your heart has an inherent sort of pacemaker. It's called a sinus node. So that's the thing that fires off electrical activity, goes up and down to generate your heart rate faster or slower. And that impulse is propagated down a pathway of electrical wires, okay? It goes from the sinus node to a thing called the atrioventricular node. From the atrioventricular node, there are these sort of superhighways that are called His bundles that propagate that electrical activity throughout the heart muscle. And the way that the heart beats in synchrony or sort of in an organized way is because those pathways are working properly, okay? If there are any disruptions along those pathways, there's highway construction, there's a car wreck, whatever, then the highway distal to that segment won't work perfectly. Does that make sense? So that's the way the electrical system works, truly that simple. And just as the heart muscle can be a focus of deposition, so can the electrical system. So it can become disrupted. And so the question is if we know that ahead of time, how can we look at it, right? And I'll show you a couple of things. When we talk in cardiology, we talk about brady and tachy. Brady is slow, tachy is fast. Okay, so that's all you need to know. And brady is the one that we see probably is the earliest kind of phenotype. And Rob and I did some work on this a few years ago now, where in kids, for example, we know that they have the disease. They're actively being surveilled. What is the earliest kind of checkbox, if you will, that they're involved? And it's probably because the heart rate is slower. That's usually what we use a thing called sinus bradycardia. So the heart rate is it's a normal rhythm, but it's a little bit slower than it should be. But we can also see unusual other heart rhythms as a part of that as well, a thing called SVT or supraventricular tachycardia. One subtype of that is a thing called atrial tachycardia. So sometimes we do see that. But this would be the common thing, is that we see a slow heart rate, okay? So a slow heart rate in and of itself is not bad. So if I work out a lot and my resting heart rate is low, in the absence of Fabry, that's actually a favorable prognosticator, right? It means I'm probably going to live longer because my heart's more efficient. This is different, though. The heart rate doesn't necessarily want to be running this slow. It's slow because the sinus node or that pacemaker is not working perfectly properly, okay? And when you have a slow heart rate in the presence of symptoms, that is an indication for a thing called a pacemaker, okay? So we can detect this stuff on monitoring, and I'll show you how we would do that in just a few minutes. This is also, I said I wasn't going to mention Kaplan-Meier's, but I lied. So this is a Kaplan-Meier curve. This is actually, we talk about a Kaplan-Meier, it means everybody starts out at 100%, and over time, how many of them sort of fade off based on an endpoint? Could be mortality or admission or whatever. And as that curve goes down, that means people are experiencing more of that endpoint. That's all a Kaplan-Meier curve is. We classically call it a survival curve. And this is a very simple piece of information. So every time you get an EKG, up at the top, it'll give you your name and your date of birth and all that sort of jazz. But then it'll give you some numbers with a few letters preceding that. One will be a PR interval, one will be a QRS interval, one will be a QT, one will be a QTC. What we are looking at here is a QRS interval. And all that is back to that electrical pathway or highway is when the electricity gets to the pumping chambers or the ventricles, how fast does it go? Okay. And it should be less than 110 milliseconds. Okay. So that top line means if you stay less than 110 milliseconds, meaning your electricity is running the way it should, you're going to do great. When it gets above that number, you start doing poorly. Okay. Easy data that is on every EKG that you have ever had, period. You can go into your patient portal and see this information. If your number is if you can see here, is greater than 110, so that means that electrical system isn't working well, ask your doctor about it. Okay. Easy thing. Oops, let me see. So the other question is, well, how do we pay attention to this stuff? So some of this information, like what I just showed you, is on a resting EKG. Some things only happen when heart rhythms present themselves, right? So let's say you have palpitations, you get dizzy, you pass out, whatever. So that is just pure luck. You may experience that symptom in my office and I have an EKG running and we can see it real time, but most of the time that never happens, okay? So the question is, how can I find that information? And so if any of you have ever seen a cardiologist, probably familiar with some of this stuff. So that's just an EKG. That's the little 3-second blip that you get on the pretty pink paper with the black squiggly lines, right? Everybody's probably had one of those. But oftentimes, especially if you're in a Fabry center, we'll ask for a thing called a Holter monitor. That's where you wear sort of a heart rhythm monitor, if you will, with a bunch of leads. It's not actively transmitting data. It's stored and then it has to be downloaded. And you usually do that for a day to 3 days, right? So for 24, 48, 72 hours. It's called a Holter monitor. Most people hate these things because of the stickers and it's hard to shower and all that kind of business, but that's one way to get at this. Next is more of a wearable device. So a little sticky thing that would go on your chest. This is just one consideration of multiple ones that are out on the market. And that gives you 7 days worth of data. And that little button up here is if you started feeling symptoms like palpitations, you would push the button. It would timestamp when you push the button, and it would look at that, you know, the heart rhythm. We would match that up with your symptoms, right? Meaning I felt I was having palpitations, but the heart monitor looked clean, then we know it's not your heart. If you're having palpitations, we looked at the monitor and there was some disturbance, then it probably is your heart, right? So it's a rule in, rule out kind of a thing. And those are very powerful. You can usually get 4 of these. So that means you get a month's worth of data, which is kind of cool. Last thing is a thing called a loop recorder. A loop recorder is what lives under your skin. It's about the size of a paper clip. It gives us up to 7 years worth of data. So it is actively looking at every heartbeat that you have for 7 years. Okay. Slips under the skin, not under the muscle. So it means it's easy to take out. And we've used these quite a bit. And we used it while I was still in Cincinnati. We used it on a case. It was a female. So most people have this incorrect perception that only severe heart disease occurs in males. That's not true. This was a female. Sue had been having pre-syncopal events, and so that means she was getting dizzy, almost feeling like she's going to pass out. Had gone through all the other stuff I have listed up here, the Holters and all that sort of jazz, never found anything. We put one of those loop recorders in. This is what we found. Those kind of jagged things that look like knife blades, that's kind of what they are. That's called ventricular tachycardia. That will kill you, okay? We saw that on one of the heart monitor on the loop. She got a defibrillator, so a shock box, right, that lives under the skin. She ultimately got 2 appropriate shocks. So that means by the proper surveillance, meaning looking forward into the future, knowing someone was at risk and making the right intervention, we may have saved her life. Okay. So that's the point of these technologies, is don't react, be proactive. So that's about the rhythm piece. And as I said, that's a huge component of what we do and easy stuff. The other thing I didn't put on there, but probably half of you have, is a wearable, right? A Fitbit, a watch, whatever, similar kinds of data that you can get. And we've used that in clinical practice as well. Not the same veracity or sort of truth that you see from these kinds of devices, but it gives us a lot of information. So we talked about the electrical piece. What about the muscle? And that's where echo comes in. And echo truly is just an ultrasound of the heart. It's just like you have an ultrasound of your gallbladder, of your baby. This is of the heart, but it's a moving structure, right? And these are the things that we're paying attention to. Whoops. I don't know if I can go back. Yeah. So this on the far left, those are both normal hearts. What we see in Fabry is usually the thing in the bottom middle there. That's where the heart becomes thickened. We talked about left ventricular hypertrophy. Okay. And then maybe 10, 15% of the time, this thickened heart will actually go on to be more of a dilated heart that doesn't squeeze very well. Okay. So the middle heart is one that doesn't relax very well. The one on the far left is one that doesn't squeeze very well. So remember, cardiac function is composed of 2 cycles: squeeze and then relax. That's called systole, to squeeze, diastole, to relax. Okay. And we used to just function on the squeeze part, right? So we can fix the squeeze, everything's cool. But the hearts that don't relax very well are about half of people in the United States that have heart failure in general. And it's a really hard problem to treat. So just being cognizant that these are the things we're kind of paying attention to, is how thick is the heart, how big is the heart, and how well does it squeeze, will give you a good sort of understanding of where you need to be. Okay. On the left is a normal heart. These are the 4 chambers. So this is the right side, the right atrium, the right ventricle. This is the left atrium and the left ventricle. That is a normal heart. This wall that separates them, this kind of white line, is called the interventricular septum. So that's the wall between the right-sided pumping chamber and the left-sided pumping chamber. Okay. In Fabry, we see thickening of that heart, or of that wall. And you can see that here comparatively, this wall is thickened. And if I cut the heart kind of like a donut, a cross-sectional study, same thing here. This is normal, where you can see that O ring. That would be a normal pumping chamber or left ventricle. The one on the right is a severely diseased one, where it's probably about 3 times as thick as normal. This is what we see in Fabry. Okay. And if you've ever worked out, lifted weights, you feel your muscles get tight and they're hard to relax, right? You pump your bicep or your quad and you notice it just feels kind of tight and clenched. That's exactly the same kind of phenomenon here. The reason it matters is in your heart. If the heart doesn't relax, it can't fill with blood. If it can't fill with blood, that blood can't go out to the body. That blood carries oxygen. So that's essential for your organs to work properly, right? So when the heart can't relax, it can't fill as well with blood, which compromises a thing called your cardiac output, which is a completely different discussion. So, and that's just general echo that we've been doing for, 30 years or something like that. I think that mode and stuff was in the 1980s. So it's been around for a while. So that's kind of the black and white version. For those of you that are old enough to remember what a black and white TV looks like, that's what we're talking with an antenna, right? That's what we're talking about, is an ultrasound of the heart. So the question is, how can we get to 2023? If I can watch, if I can play Madden 25 or whatever on my PS5 with all these great graphics, why can I do that for my heart imaging? And the point is, you just have to ask for it. So now we can do fancier tools to look at your ultrasound. And so this is that same picture we were talking about. So these are the 4 chambers. They're inverted in this view, so flipped upside down. But the point is that we can actually use fancy techniques now to monitor each little area of the heart muscle. And that's what all these little dots are. So if you think about it, all of those little areas that are punctated with those little dots, their job is to squeeze and relax, squeeze and relax. And usually we just look at it globally where the entire heart is squeezing and relaxing. That's called your ejection fraction. Okay. But the point is, we know that these tiny little areas, like certain segments along that pathway, could be disrupted. We would miss it by just looking at a conventional ejection fraction. So if the doctor says, hey, your ejection fraction is 56, you're completely fine, don't worry about it. Well, actually, it turns out if we look at these discrete areas and say, well, I want to drill down and know if this part of the highway is squeezing and relaxing appropriately, we can do that with this thing called strain imaging and strain rate imaging. And it does exactly that, as it tells us, is all of the heart muscle as healthy as it should be? You can do this in any echo lab in the United States if they have the software, okay? And this is something you should ask for because it actually, this particular patient had a normal ejection fraction, so they went to the cardiologist, and it's like, yeah, your EF is normal. But if you look on the left, you see the normal, it's all nice and red. That tells you those areas are squeezing and relaxing appropriately. When you see color disruption, which is what you see on the right, it was a patient with Fabry, it's not red anymore. You see green and yellow and purple and all these other sorts of colors. What that tells us is that the heart muscle is diseased in those areas. But if I were relying just on an ejection fraction, I would have told you your heart was completely normal, live long and prosper, right? And we don't want that because the heart muscle is diseased. And if Rob calls me and says, hey, does this patient have heart muscle disease? If I looked at just the ejection fraction, I'd say no. But if I looked at the strain, I'd say, yes, patient has a cardiac phenotype. Okay, so that's an important piece of information. You can get this almost anywhere, both in adults and in kids, okay? But if you go to a Fabry center, they may do echo, and it's mostly because of the valves at this point. We like to use a better imaging modality. And so this is the kind of 4K high def, big screen, watch the Super Bowl thing. This is the cardiac MRI, okay? This is what we use. And there's some basic reasons. One is because it's very reproducible, and the data have a lot of integrity. We can move the heart around. It gives us a 3-dimensional reconstruction. But the biggest thing is it actually can look at the heart. I can look at the muscle. So this is what we care about in this particular discussion, okay? And this is what an MRI would look like. And this is kind of that black and white version of MRI. So you see on the far left, this is a thickened heart. So it's all the way around, the muscle is thick. So that's that left ventricular hypertrophy we're looking for in Fabry. But then if you ever get an MRI, they'll usually give you an IV, okay? And they administer a contrast agent called gadolinium. And gadolinium is interesting because it gets pumped into the heart muscle. And if there's no heart muscle disease, it just flows back out. So go in, go out, okay? And that's represented on the far right is that the areas here that are kind of black, if you will, this out here, that's normal muscle. But in diseased areas, that gadolinium will get hung up. It can't get out of the heart muscle. And that's what is called delayed gadolinium enhancement or late gadolinium enhancement. So if you ever see an MRI, it'll say LGE or late gadolinium enhancement. What you want to see is none, right? You don't want any. When you see it, which is what's depicted here, that's evidence of scar in the heart, which is a problem. We do a lot of cool things in cardiology now. One thing we can't do yet is reverse scar to any great degree. So once you get to that point, it's a problem, right? What's the problem with scar in the heart, you might ask? Well, who cares? One is that it's a real nidus for those rhythm problems I was talking about. It's the roadblock on the highway. That's what the scar is. The other piece, scar don't squeeze. We want your heart to squeeze, right? Scar doesn't squeeze. So that's a problem. But there's even more advanced stuff to that. And I'm encouraging you to take notes and ask your providers about these things. is that if you have Fabry, you want a cardiac MRI. Okay. And if possible, you'd love to do it with a thing called T1 mapping. So that gadolinium agent I told you about is a great agent. It has some limitations we won't go into today, but one of the biggest ones is this: if you have advanced kidney disease, which we know is sometimes common in Fabry, meaning if your GFR is below a certain number, usually it's below 40 in most labs, you cannot receive that agent because it is a potential toxin to the kidney. It causes scarring of the kidney. So the question is, well, I want to get the MRI. I want to look for the scar tissue, but I can't give you the gadolinium. How could I do it? It's with this business, which is called T1 mapping. And so this means we can look at the same kind of stuff without giving the contrast agent, okay? And this is what a heart would look like on the far left as a normal, so as a non-imaging doctor, so I don't look at pictures all day long, they need to make it really simple, which they did, thank goodness. So they make it all color-coded. And if it's all the same color all the way around and it's the target color, which is here, that means everything is cool. Okay. But then you look at this middle heart, which is one with Fabry. It's obviously thicker than this one. That donut is bigger. And the color's not homogeneous anymore, right? See how those little punctate things are different colors? And as you're moving up the spectrum, it tells you those areas are diseased. Okay. And if you look on the far right, this is that patient that received the contrast agent. And you see, I told you where that stuff gets hung up. This white little line right here is the scar. Okay. Well, it matches up really nicely over here with the T1 picture. So the point is, I got the same information without giving the contrast agent. Does that make sense? Which is good. Okay. So something you can ask about in your systems. These are some data we just published recently that we think are kind of interesting. And it's part of the phenotype we haven't really talked about too much in Fabry, but we have shown it's pretty common. And it's a thing called lymphedema. And once you see it, you'll never forget it. Okay, so I'll show you a picture. Okay, this is what lymphedema, significant, severe lymphedema looks like. So in the past, you ever heard of like a thing called elephantiasis? Does that term sound familiar? Kind of looks like this, right? So this is extreme swelling of any part of the body, but typically lower extremities, can be upper extremities, whatever. We see this nowadays in the coronary in the absence of Fabry in people that have breast cancer, for example, that have had lymph node dissection and whatnot. You'll see ladies wearing compression things on their arms. That's exactly what this is. It's the same idea, but this is lymphedema. And you see a $5 bill down there to give you a scale comparative, right? This is a problem. How would you walk? Probably hurts. How do you wear clothes? How do you put on shoes? All that kind of stuff. The reason I show you this is a very simple one. Lymphedema classically is not really thought of as a cardiovascular problem. Okay. It is a problem, though, because of the lymphatic system, which is a part of the circulatory system. But the reason I'm showing you this is because if this patient showed up in any ER in Greensboro or at Durham or in Cincinnati or in Houston, they're going to be told they're in heart failure and they're going to be pummeled with diuretics. Okay. So the first thing you're getting is an exposure to an intravenous diuretic called Lasix or furosemide, okay, to make you pee, because we think this is all because your heart ain't working properly, okay? The problem is in this setting and in this particular patient, the heart was actually working okay. The heart was not the problem here, okay? So if you assume the heart is the problem and you give water pills to try and mobilize the fluid, but you don't really need fluid pills, what happens with that? Be like I gave any of you a diuretic and you didn't need it. One, you're going to hate me because you're going to the bathroom all the time. Two is you're going to feel really bad. We're going to drop your blood pressure. So it's a thing called hypovolemia, so low blood volume, which leads to hypotension, which is low blood pressure. What happens with low blood pressure? Well, you feel bad, you have headaches. The other thing is you damage your end organs. We would damage your kidneys even more. Okay, so you already have a kidney that is not great in Fabry, and I give you medicine to treat a disease that isn't really the disease that we are talking about. So we've actually put you further behind the 8 ball, and on top of all that, this ain't gotten any better. Okay. So I'm showing you this just so you are familiar that if you develop these kinds of findings, talk to your provider and bring up the idea, could this be lymphedema, especially if your cardiac imaging is completely fine. Okay. This kind of recapitulates everything I've talked about. Once you have these problems, it is near impossible to undo. So you want to be as proactive as possible, looking upstream to find these problems. These are some of the things that you've heard about in various ways throughout the day that we have talked about as well. But some of the things that you can begin to look for on imaging and Holter and all that kind of stuff. The one thing that's very interesting, I told you about the MRIs, this is down at the bottom. In most, that T1 thing I was talking about where we have the cool little colored donut, most diseases, so if you had high blood pressure, if you had heart failure, if you had aortic stenosis, blah, 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 that number goes up. So let's say the normal range is 900 to 970 or something, okay? Most diseases, the number goes up to 1100, 1200, 1300. Fabry is the only disease we know where the number goes down. So it's actually even easier for your providers to know if your heart is involved. If your number is below the reference range, then that tells you probably have cardiac involvement. Last thing, and then we'll sum up. What could we do to start identifying people earlier, right? So as you've probably heard and you all know, we missed the boat usually by at least a decade when it comes to diagnosing Fabry, from presentation of symptoms to when we actually make a diagnosis. And that just tells us, one, as I said, our awareness is not high. It's just not in the top 10 things we're thinking about usually if someone comes in with hypertension or stroke or whatever. So the question is, how could we use things like artificial intelligence or machine learning to diagnose, or at least give us an idea of who may be at risk of having Fabry? And that's exactly what we did in this particular paper, meaning if I look at a bunch of electronic health record data based on a few important points that we know are common in Fabry, could we identify people who likely have Fabry but have not been diagnosed? And the answer is you can. Same thing as we're starting to apply that now is, could I look at your echocardiogram or your MRI and predict when you're going to have heart involvement or heart disease? And the point is you can. So that's kind of where the field is going, which I think is kind of cool. So in conclusion, lots of diseases that we've talked about. You just basically did a cardiology fellowship in the last 40 minutes because everything that we do is all there. And we just know if you don't catch it, it just delays beneficial strategies. And I do want to take a couple of questions if we have time. A couple of things important. We treat males and females the same when it comes to doing their diagnostic stuff. Okay. Some people might think, well, we need to be more thoughtful or more aggressive on the males. I don't agree. I'm not talking about 4-year-olds. I'm talking about adults. We would approach them exactly the same. And I think it just gives us an opportunity. The other thing I counsel you strongly is that people that are not familiar with Fabry, you see someone, they make the diagnosis, you talk to Jerry or Angela, whomever, and they say, hey, you need these lists of things done. Okay. One of them is an echocardiogram. The other is an EKG. You get an echocardiogram, you go see a cardiologist. The echo looks fine. The cardiologist says, I don't know why you're here. This echo looks completely fine. You don't need to come back and see me ever again. Stop and say, that is incorrect. This is a longitudinal disease and things change over time. And where I see people in the most trouble is because they saw a cardiologist 10 years ago. They were told they did not need to follow up. Disease progresses, and then they come back in with heart failure, which is catastrophic, right? Let me explain. If you get admitted with heart failure in the United States today, your 5-year mortality is 45%. In 5 years, half of you will be dead. You do not want that. Okay. So that's why you got to stay on top of this stuff. These are just some of the things we've talked about. I do think AI probably has a role. And this is my email. If you guys ever want to reach out or have any questions, I'd be happy to provide whatever information I can. So thank you, and happy to take on some questions if we have time.